We are live.
Good evening, everybody. I welcome everyone to 441st lecture of today. We are currently running in the 51st Cataract module. This is a masterclass, and speaker of today's session is Professor Dr. Boris Malyugin, sir. He's a renowned Russian ophthalmologist. He's going to talk on small pupils and loose zonules. Welcome, sir. We have Dr. Kiran Kirtani ma'am to moderate today's session. Ma'am has completed her MBBS from BJ Medical College, Ahmedabad, MS from MNJ Eye Institute Civil Hospital, Ahmedabad, where she received a gold medal. She finished a senior residency from DDU Hospital, New Delhi. Currently, ma'am is a senior consultant at Center for Sight Eye Hospital, New Delhi. She's a trained and certified femto cataract and refractive surgeon. She's a part of organizing secretary of prestigious PG training program iFocus and also a part of organizing secretary of IIRSI. She's a faculty with iFocus, IIRSI, and various other conferences. She's authored multiple book chapters and publications in index journals. Welcome, ma'am.
Thank you, Dr. Kritika. Thank you for the generous introduction. We are very, very grateful to Dr. Kamaljit sir and to Dr. Boris sir for joining us today for the International Masterclass. We are very lucky that sitting in the confines comfortably in our homes and hostels, we are learning from the master himself, better known as the Lord of the Rings. Before I introduce him, I would be introducing Professor Dr. Kamaljit Singh sir, who's our chairperson for the day today. Sir has done his MBBS and MS from MLN Medical College, Prayagraj. Past, he has been the HOD at MLN Medical College. Sir has also been the president of IRSI UPSOS and has served as an editor in various prestigious journals. Currently, sir is HOD at United Institute of Medical Sciences, and I am very proud to say that he's a family member as a senior consultant at Center for Sight, Prayagraj. Chief Editor of Ophthalmology and Allied Sciences. Sir has been awarded by the WHO Fellowship in Medical Retina, USA, and fellowships from the Wills Eye Hospital, Philadelphia, and Massachusetts Eye and Ear Infirmary, Boston. Having published many books in ophthalmology, the most popular book written by him has been Small Incision Cataract Surgery. Sir is an academician par excellence and a guest speaker of international repute. Thank you very much, sir, for joining us today. I would now like to introduce
Thank you so much.
Thank you, sir. I would now like to introduce Dr. Boris. Once again, I will say, sir is the Lord of the Rings. We'll be very grateful to him for, teaching us and bringing us to the world different innovations and patents which he has brought over with new instruments that are there in his name and his under his patents. Sir is the Professor of Ophthalmology and Deputy Director General at the S. Fyodorov Eye Microsurgery Federal State Institute. And he conducts clinical and research in these institutes and is responsible for research and development and education programs. He is the president of Russian Ophthalmological Society since 2013, editor-in-chief of 2 Russian journals, editorial board member in 9 foreign journals, a prolific researcher actively involved in developing new IOLs, designing new microsurgical instruments, laser technologies, genetics of corneal pathology and ocular pharmacology. Sir has made significant contributions to the field of ophthalmology, especially in the development of innovative surgical techniques and devices. Sir invented the Malyugin ring, a device used in cataract surgery to stabilize the iris in patients with small pupil, and we'll be learning about the same topic today. Known for his expertise in cataract and corneal surgery, anterior segment reconstruction, he's done more than 11,000 surgical procedures, having published more than 280 papers in scientific journals, 47 papers in leading international journals, 36 book chapters, 153 patents, 47 patented surgical instruments, keynote lectures, presentations, honorary lectures, awards for best videos at international ophthalmic film festivals. Sir has been a beacon of light in the world of ophthalmology for all the students and for all the, and very generously he has been sharing his scientific knowledge across the globe. Sir is an active member in more than 10 of the largest international and supranational professional scientific organizations. His contributions have earned him recognition as one of the leading figures in modern ophthalmology. So before I request Boris sir to start the lecture, I would request Dr. Kamaljit sir to introduce, to speak a few words about Boris sir and introduce the lecture topic.
Dr. Boris is a wonderful
surgeon, we all know about him, and all Indians know, and he's a household name today. And about small people and these big zonules, Dr. Malyugin can give us a lot of details, and we'll be learning a lot today from him. Thank you.
With that, I think, sir, can we start the lecture?
Yes, we can start. Yes.
Welcome, sir.
Thank you very much. Should I again share my screen? Okay. First of all, I would like to thank organizers for the kind invitation to join you today for this webinar and to discuss the topic of small pupil loose zonules and pseudoexfoliation. And I will be happy to share with you my experience in that. First of all, small pupil, we know that it is a challenge for both new and novice and experienced cataract surgeon to have a patient with small pupil. And the problem of small pupil is not only the geometrical issue as shown here, but also comorbidities that can be local or systemic, such as this one, which is glaucoma, previous glaucoma surgery, uveitis, and some concomitant changes in the ocular tissues. So in these cases, I do like to manage them in a stepwise approach, starting from injection of intracameral mydriatic, followed by viscodilation, posterior synechial lysis, pupil stretching, and then consider about pupil expansion devices. Intracameral mydriatic injection is a well-known procedure. You can use different pharmacological substances such as phenylephrine, epinephrine, or a combination with anesthetics and non-steroidal anti-inflammatory drugs. There are several commercially available formulations that are here on this slide. Synechial lysis is another tool that is useful to apply for patients with synechia. Usually these synechia are not very strong, and you can easily lyse them by the instrument introduced through the main or side port incision. And it's kind of an easy maneuver because there is no tight adhesion in between the lens capsule and the iris in these cases. Pupil stretching can be considered in patients with very fibrotic and small pupils, where when actually retropupillary membrane was formed, and basically in these patients, you don't worry to cause trauma to the sphincter of the pupil because there is no sphincter. It's actually now a membrane that is holding the pupil in constricted state. This is another example of the membrane, which is shown here. Usually, this kind of membranes are having inflammatory origin, and again, they can be lysed by cyclodialysis spatula or other instrument. And it is a good idea to utilize microforceps. And you see how I'm now peeling this membrane, and it's now located on top of the cornea to visualize the presence of this membrane. And again, this is another clinical case when there is no sphincter muscle, but rather the fibrotic tissue that is replacing now the muscular tissue. Again, this is a result of inflammation and I now gently peeling it, and by peeling you can sometimes have bleeding, but this is usually not very significant if there is no intensive iris neovascularization. So you can block this bleeding by injecting additional viscoelastic into the anterior chamber and kind of compressing the vessels and waiting for a couple of minutes. Sphincterotomy can be reserved to the cases where the patient is having very significant thickening and fibrotic transformation of the pupillary margin, which cannot be managed by membrane peeling, because it's not a membrane that is attached to the posterior surface of the iris, but rather the transformation of the iris tissue into the fibrotic scar tissue. So you need to reach the softer iris, which is not being converted into the fibrotic tissue. And it's possible to do that utilizing sphincterotomy using fine 25 gauge instrumentation. And again, when you cut the iris tissue, you may have some bleeding, and you need some intracameral cautery or use viscoelastic to compress the vessels located in the pupillary margin. So pupil expansion is another option. Here is an example of pupil expansion device that I developed several years ago. This ring is being now injected into the anterior chamber, and I'm retracting the injection device and utilizing a special ring manipulator to insert the last scroll of the device and to center the ring in order to have a nice centered and wide pupil. After cataract removal, the ring is disengaged from the iris by the same instrument, and utilizing the injection device or insertion device, it is easy to inject the ring or retract the ring inside the tube of this injector device. Sometimes it's helpful to press on the ring so it comes easily inside the injector tube. And you can see that at the end of the procedure, pupil restores its natural size and circularity. Pupil expansion rings are very frequently used, but also iris hooks is another very useful device that many surgeons like to use in their surgical procedures. However, currently it is a growing number of evidences showing that pupil expansion rings of different designs are in most cases much easier to use. They require less operating time. They do not require extra incisions, provide stable pupil during surgery, and minimizing postoperative pupil deformity. And these are options that are currently on the market, and definitely you can choose one the device that you would like to use based on your personal preferences, availability, and economical sides of that technology implementation into the clinical practice. So cataract surgery, when it is most frequently combined with the small pupil and loose zonules, is definitely pseudoexfoliation cases is one of the major reasons for the pupil not to dilate and for the zonules to be lax. Pseudoexfoliation is an age-related systemic disease with ocular manifestations, and we know it's characterized by deposition of the whitish gray pseudoexfoliation material on the anterior chamber structures in the ciliary body, pupillary margin, corneal endothelium, and it is genetically determined and environmentally influenced disorder. Risk factors of these conditions are including zonular weakness, poor pupillary dilation, blood aqueous barrier disruption, IOP decompensation leading to glaucoma, and endothelial keratopathy. So this is a nice example of patient of having fuchs endothelial dystrophy and pseudoexfoliation, and we can see this pseudoexfoliating material, which is located at the very center of the corneal dome, and it can be visualized by intraoperative OCT during surgical procedure. There are several preoperative considerations in these patients. First, we can expect the incidence of phacodonasis and lens subluxation in these cases, reaching up to 10% of cases, which is much more significant than in age-related cataract cases. Also, we have to check the reduced anterior chamber depth, because it's an indicator of zonular instability, especially when you're comparing the anterior chamber depth of both eyes, and you see that on one eye it is much more shallow, and the anterior chamber depth less than 2.5 millimeter is a very significant risk factor, which is increasing the rate of intraoperative complications such as posterior capsular rupture more than 13%. Intraoperative complications in these cases are also higher. They are reaching about 9% versus 1.8% in the regular cases. And capsular rupture also, the rate of capsular rupture is also increased up to 27% versus 2%. And obviously, that depends on surgeon experience and the comorbidity of the eye. So it's kind of variable. There's a variable numbers in that because of the different patients' population. So surgical goals in these cases, first of all, is to preserve capsular bag for IOL fixation, and also to achieve stable IOL position that will last years after the surgery. With surgical technique, I have to mention that it is necessary to have a complete and careful hydrodissection, reduce fluidic parameters. However, I do reduce fluidic parameters only in cases when I'm not using pupil expansion devices. If I'm using pupil expansion ring, there is no need to change your fluidic parameters at all. It's a good idea to increase ultrasonic settings, increase the ultrasonic power. In this case, the ultrasonic needle cuts through the lens much easier, and you do not causing the stress on the zonules that are not in a healthy condition, usually in these cases. So zonular friendly lens manipulations are including those that when you are cracking and cutting the lens into smaller pieces and causing much less stress on the zonules by reducing the number of manipulations, by reducing rotation of the nucleus, and trying to do all manipulations in situ. One of the very helpful device is a capsular hook, and this is one of these hooks, and this one is made by MST. In the upper left picture, it's a kind of first generation of the device. on the left lower picture is a David Chang modification of that device. As you can see from that picture, the tip of the hook is modified to reduce the gap in this area. So what's good with these devices is that actually you can not only expand the pupil, which was not really necessary in that case. You see very nice mydriasis, but it is a matter of illustration to show you how the equator of the capsular bag is supported by the capsular hook, and there is a gap in between the curved area of the hook and the anterior capsular axis. And with these devices, the capsular axis is not extended, it's not under stress, and equator of the capsular bag is very well supported, and you has much less chance of causing tearing and stressing of the anterior capsule. Capsular hooks, as shown here, can be implanted in a different patterns. On the left picture, you see 3 capsular hooks are being implanted. On the central picture, you can see 4 capsular hooks supporting the capsular bag. And in some cases, when the pupil is small, I actually like to use a combination of the Malyugin ring and the capsular hooks that help me both to expand the pupil and to support the capsular bag. There were some proposals by several surgeons of hooking the anterior capsular axis with the scroll of the device. However, I'm not very much in favor of that technology, but rather use 2 separate devices, one for pupil expansion and the other one for pupil support, because even if you catch the anterior capsule with the scroll of the device, you still need something to support the equator of the capsular bag, because at the final steps of phaco emulsification, when the zonules are very loose, so you actually aspirate the equator of the capsular bag, and you want to avoid that by proper use of capsular hooks. Capsular tension rings are the other group of very useful devices. We know the classic capsular tension ring that goes in various sizes. And we also know the Henderson modification of the capsular tension ring, which is having this configuration, allowing the surgeon to much easier evacuation of the cortical material, which is usually compressed at the equator of the capsule bag when you are injecting the ring at the earliest stage of phaco emulsification procedure. And this is the device that I designed, which is a modification of the Sioni ring. And this is a very good modification from my point of view, because the ring is fully retractable inside the injector tube, and you can use it in a very controlled and precise manner. So capsule tension rings support missing zonules, circularize the capsular bag, center it, and tighten the posterior capsule, which is very important. You see how the cortical material, which is trapped by the capsular tension ring, shown here to the fornix, is not so easy to evacuate as shown on that video. And that's why I mentioned to you the Bonnie-Henderson modification. With Bonnie-Henderson modifications, it's much easier. Also, if you don't have Bonnie-Henderson design, so tangential aspiration stripping maneuvers will help you to evacuate cortical material much easier. So this is the case with extreme zonular laxity, and I tried to to inject the ring, but I realized that the capsular bag starts to displace. So in that case, I do like to utilize the hook in order to catch the eyelet of the CTR. With this maneuver, you cause much less stress on the capsular bag, and you can inject it in a very easy and controlled manner. And in this case, I will be using 3-piece IOLs, which I love to use in cases with instability of the zonular apparatus. And the idea here is to inject the IOL into the sulcus with the optical elements located in the sulcus, while optical element will be located in the capsular bag by the optic capture maneuver, which you will see in a minute. So I'm now implanting the second optic into the sulcus, as shown here. And with that, the lens is actually positioned very well in the sulcus. However, you don't want to leave this lens in the sulcus because of the sharp edge of the anterior surface. So now I'm holding with the right hand the anterior capsulorhexis edge, and by pressing on the optic of the lens, I inserted one part of the optics inside the capsular bag, and now doing the same maneuver with the contralateral part of the optics. With that maneuvers, you have kind of double fixation of the IOL, fixation in the sulcus plus in fixation of the optic in the capsular bag, and that helps you to prevent late IOL capsular bag complex dislocation. So this is the nice presentation of different modifications of the capsular tension ring, which is done by Jiri Sendeling. It's a surgeon from Czech Republic. And you can see here this nice model showing you how to utilize different type of CTRs, different modifications of these CTRs, and fixate these devices to the sclera with the help of the suture. You can see this is a Sione capsular tension segment that can be kept in place with the help of the iris hook or with the help of the suture. And here, of course, in this particular cases, you will expect some complications. First of all is IOP that can be increased, and the risk is much greater in the early postoperative period. And we have to monitor these patients because actually the trabecular of many of these patients is blocked by pseudoexfoliative material. The other group of complications is lens capsule related, and you can see here that zonular ruptures are reported in the literature to be significantly higher as opposed to the regular cataract cases. And my conclusion that small pupil and zonular weakness presents significant challenge for experienced cataract surgeon. Appropriate machine settings and zonular friendly manipulations are mandatory. Visualization is very important, and apart from using intracameral mydriatics, you should consider utilizing pupil expansion rings, which is my preference, or hooks. And also you have to get capsular tension rings always ready. And of course, because we have a higher risk of capsular complications, you should consider a backup plan with 3-piece IOL ready in these cases. And of course, you have to be prepared for capsular complications and have all these tools ready for you. And I thank you very much for your kind attention.
Thank you very much, sir, for such an enlightening lecture. I have so many questions to ask, but I would first ask you one question. Doesn't your heart race up and down when you're doing such maneuvers?
Yes, of course, the heart rate is definitely going up and down, although we do not monitor surgeon's heart rate during the surgery, but we're doing it for the patient. However, I've seen one paper that was written by British surgeons. They actually monitored the heart rate of the surgeons at the different steps of the phacoemulsification procedure, and they were kind of trying to find what's the most stressful step of the surgical procedure. To know that at the beginning and the starting of the procedure, so kind of surgeon is a little bit more stressed, and then when you go through the procedure, you kind of relax and when everything is going smooth, then your heart rate stabilizes. So it's kind of it's expected to be up at the beginning, but then plainer during the course of the procedure.
I was mesmerized to see how you have done the optic capture of your three-piece IOL. It was very beautiful.
Yeah, I think it's a nice technology,
Yeah.
and I love using it. And I said I love using this three-piece IOL in these complicated cases. At least I would like to have them in the OR ready for me.
Right. Sir, I have one question before Dr. Kritika brings up the questions which are coming to her. You mentioned that there are two goals to stabilization, or rather, in a case of pseudoexfoliation, there are two goals that we are looking forward to. First is a short-term goal of stabilizing the IOL inside the bag, and second is that this stability is maintained for many years, for a long time to come. So, do you routinely recommend a placement of a capsular tension ring in all the cases of pseudoexfoliation, or only those cases where you are observing a zonular weakness? Sir, am I audible?
The audio is interrupted somehow, so.
So I would just repeat that question, sir. Do you recommend that the CTR or the capsular tension ring be routinely put in all cases of pseudoexfoliation, or only where you've seen zonular weakness?
I think that it's a debate, and one of the kind of, I love to use them in most of my cases. There are some economic considerations because in some countries, the cost of CTR is equal to the cost of the implant. However, in Russia and I believe in India, it's not the case. So the CTRs are quite cheap and easy to use. So I think we can use them much wider, and it's a good idea. Having said that, I should emphasize that ECTR does not prevent IOL capsule bag dislocation, but I think it makes life easier during the surgery, and it makes life easier in late postoperative period when you would like to, when there is a IOL capsule bag complex is dislocated and you need to refixate the lens, so you can use the CTR as a fixation point for the suture.
Sir, I would request Dr. Kritika to bring up the questions which have come for you and Kamaljeet, sir. Dr. Kritika, do we have questions?
Yes, ma'am. Am I audible?
Yes, you are.
I think that. Okay, ma'am. Sir, I have a question, sir. How about stretch pupilloplasty versus pupil expander, sir? Like, what is then? Hello?
Sorry, can you repeat that, because the maybe in my internet connection is not very good. So I heard about pupil expansion, but what was that question about?
Stretch pupilloplasty versus pupil expander, sir. Which one to prefer in what case?
Pupilloplasty, if you mean pupilloplasty after the pupil expansion, use of pupil expansion device, so it's very rarely recommended. Usually, there is no need for that. If you think that the pupil is expanded, such as in cases of severe fibrosis, you kind of wait what kind of pupil size you would like to have postoperatively, because sometimes you do not want to have problems with visualization of the retina, and especially in myopes, in young myopes, when you have to check the retina. So you don't want the pupil to be very small. So I just say that in most of the cases, it's not necessary. However, sometimes you may consider that.
So in cases where their pupil is small because of uveitis, in the cases of uveitis, do you recommend still the stretching of the pupil for expanding the pupil size intraoperative, or a device such as an iris hook or a ring is better?
I think in general, if you want to implant the pupil expansion ring, and the pupil is very small, like 1 millimeter, so you cannot do that technically before you stretch the pupil a little bit and that gives you some space to inject. If the pupil is like 3 or 4 millimeters, you can go and inject expander right away. However, if it's very small and if there is a pupillary membrane present, so it's not possible to do that at the very beginning of the procedure.
Right. Kamaljeet sir, with your expertise in small incision cataract surgery in such huge numbers, do you routinely tend to put CTRs in patients even in SICS cases where there is a case of pseudo exfoliation?
Normally, I don't put CTRs in pseudo exfoliation. In SICS, in phagoemulsification, yes, of course, I put CTRs. There are 3 questions from Dr. Boris from my side. Preoperatively, how do you manage? Give steroid drops for some time to these patients having small pupil, or you straight away go for surgery? 2-3 days prior to surgery, you give non-steroidal anti-inflammatory drops or steroid drops or not?
The sir is asking the use of preoperative non-steroidal anti-inflammatory drugs. So whether 2 to 3 days prior to the surgery, do you routinely recommend NSAIDs or any form of steroids to patients who you are suspecting IFIS or you are having pupillary non-expansion?
I think it's a very good idea because I do like to use non-steroidals. When you expect manipulations with the pupil, it's a good idea to start non-steroidal drops prior to surgery. There are some publications showing that not only in kind of very complicated, such as uveitis cases, but in kind of regular not very well dilated pupils, non-steroidals help very much. And there are some commercial formulations, including non-steroidals, are including in the formulation of non-steroidals that are injected into the anterior chamber.
Intraoperatively, do you give triamcinolone in all cases? Triamcinolone in all cases, Sapinone or chemical, whatever?
I'm not quite sure.
Triamcinolone. So sir is asking about usage of triamcinolone.
Triamcinolone. No, triamcinolone I'm not using for kind of, postoperative care as some surgeons do, because I was mentioning triamcinolone to be ready in cases when you need vitrectomy and if you're having a capsule rupture or vitreous is coming through the loose zonules surrounding the equator of the capsular bag. This is medication that is reserved for these cases, but I'm not injecting it at the end of the procedure routinely.
What is the minimum size where you would not do any intervention, like stretching the pupil or putting a Malyugin ring? So 6 millimeters, 7 millimeters, or what?
So minimal pupil size for implanting the Malyugin ring is with the current second generation devices 2 millimeter. With the first generation device, it used to be bigger. It used to be 2.5, 2.7. But with the newest generation, it's 2.0. And sometimes I had a chance to inject through the 1.8 millimeter incision. So it's kind of friendly with respect to the incision size.
Do you do peripheral iridectomy in all these cases of uveitis, old uveitis, or not?
I do what? Sorry, Dr. Kamaljit?
Peripheral iridectomy.
Peripheral iridectomy. Frankly speaking, no. I'm not a big fan of peripheral iridectomy at the time of the surgery. So there are some iridectomies from previous glaucoma surgery that you can see on some of my videos, but these are not intraoperative peripheral iridectomies that I done during the surgery.
Thank you so much, sir. Thank you so much.
So my question here would be that you were saying that if there is vitreous loss which is occurring around the zonules, then in such cases, how would you manage the CTR insertion?
When there is a kind of vitreous coming around the zonules, so definitely you have to be very careful because in these cases, even if you're using capsular hooks, so you're kind of using 3 or 4, you have to keep in mind that the areas in between capsular hooks still are not protected, and you may have this issue. So you have to watch carefully. One of the kind of tricks is that you point your phaco and irrigation aspiration handpiece towards the capsular hook. So it's not facing in between the hooks, but rather towards the hook. So in this area, where you have to be sure that the capsular fornix is supported by the hook. Also, there is another useful maneuver is to utilize gemsonolone in these cases when you can visualize these strands and use dry aspiration, not kind of regular aspiration, just to remove these strands, and that's it.
Sir has mentioned two very important things that the young doctor should remember, that the cortical matter should be removed completely, as sir has mentioned, because it might get entrapped into the CTR or some device that we have put in there. So that is one point that is very, very important. The other point is that you should try all the means, as he has mentioned, that first he puts dilators and then stretching, and then finally, if it does not improve, then he goes ahead with your devices. So these are some of the important points that one has to take care of. This cortical matter I was not very sure about, and sir has mentioned it very dogmatically, and one should, of course, take out the cortical matter and then proceed further.
Thank you, sir. Dr. Krutika, do we have any further questions for sir?
Ma'am, there is one question for sir on YouTube platform. And the question is, in case of tonic pupil, what is the preferred device to dilate pupil?
My preference, personal preference is also is always the Malyugin ring. I tried all the devices that are currently on the market, and I still think that is kind of a gold standard. But I can understand that it's not it may not be available in every country. So it depends on what you have in your kind of particular circumstances, and then go from there.
Sir, I have a question. In case intraoperatively, if capsular hook is not available, can we use iris hook, though not very efficient as much as capsular hook? Can it be used?
I've seen many times surgeons using capsular hooks to support the anterior capsule. And I'm not a big fan of this technology, specifically because of the absence of the capsular support at the equator. However, if you consider implanting the CTR a bit earlier in these cases, so you may have some capsular support that comes from the CTR, and the support from the hooks hooking the anterior capsulorhexis. So you may have this kind of combination that is viable. The only thing that I will not recommend to extend the rhexis very much, because in these cases, when the capsule is very dystrophic and it's thinner than usual, so you can easily break it by causing the stress and stretching it. So basically, I don't think it's a good idea to extend very much. So probably you can do capsulorhexis a little bit bigger in size that help you to prevent that. However, sometimes you first do capsulorhexis and then people starts to constrict, and kind of, it's easier to say than to do in some of the cases. However, if possible, bigger rhexis is a good idea.
That brings me to another question, that there are patients in whom you believe that you could do a rhexis and probably proceed with this case, but these patients are probably having an intraoperative floppy iris syndrome, and once you've finished with your rhexis, the pupil tends to bog down. Is it still safe to use a ring in these cases, and is there any special technique that you need to use? Because in iris hooks, there is always a problem, especially in cases of hard cataracts, there becomes a possibility that instead of engaging the iris, you'll end up engaging the capsular rhexis margin and tearing it, as you rightly said. So is a ring a safer device in such cases?
I have two comments on that. First is that ring is very helpful in IFIS, and it was shown by David Chang in his publication that it is very easy to manage these cases with the Malyugin ring. There were some computer modeling made by David Lockington also showing that the billowing of the iris is very much reduced when you're utilizing the ring. Having said that, you have to be aware that the ring restricts the central part of the pupil from being aspirated. However, if the iris is extremely floppy, the periphery of the iris can still bulge, and sometimes you can face incarceration of the periphery of the iris into the side port incision. In these cases, it's a good idea to utilize a little bit heavier viscoelastic and use it in a donut fashion, kind of to put some additional pressure on the periphery of the iris in order to avoid this issue. It does not give you a lot of trouble, but definitely it restricts your maneuvers, and you want to avoid that.
Right. Dr. Kritika, anything else?
Ma'am, one more question. Sir, in case where there is pseudo exfoliation, as we were discussing prior, which one do we prefer? Standard CTR or a modified CTR? If it is a progressive, because we know it is a progressive zonulopathy, so which one is preferred, sir? A standard one or a modified one?
I like standard CTR. I use modified CTR for cases with usually with the kind of Marfan syndrome, the congenital anomalies. Sometimes I had a chance to use these devices in very significant zonular laxity, but most of these cases, most of my cases in my practice of the modified CTRs are with this Marfan and hereditary dislocations, young patients, and so far and so forth.
So there is one question, and the question is, do you recommend combined trabeculectomy and cataract in case of associated glaucoma?
I'm not against that. So we do quite a number of combined cataract cases. There is still a controversy of the level of IOP you should consider appropriate for combined surgery. In the literature, I think there is a consensus now that IOP up to 25, 27 millimeters is appropriate to consider combined cataract procedures. However, anything more than that, you would like probably to do trabeculectomy first and then follow it with cataract surgery for the kind of obvious issues of not having very significant pressure drop that may happen during procedure with some evident consequences.
Right. So, Kamaljeet sir, anything in addendum that you would like to ask or you would like to comment on the topic, sir?
Nothing more. We have had enough of discussion, and it is very, very exhaustive. And sir is always very nice. We have visited Fadrov Institute long time back, and we wish to come to Fadrov Institute once again to see how they are doing there. So, thank you so much. Thank you all. Thank you, Kiran. Thank you. And thank you so much, Boris. Thank you so much.
Thank you very much for having me. Pleasure seeing you all and participate in this nice event.
Thank you very much, Boris sir. It was really an intensive and very, very learning and meaningful lecture, especially for us, because now we are coming to the stage where we are trying to cross the borders, but yet very, very scared. So especially your videos will stay in my mind, and I'd like to go through your YouTube videos once again to use them in my surgeries. Grateful, sir. Thank you very much. And good night. Thank you, Kamaljeet sir. Thank you,
Thank you. Thank you so much. Thank you. Good night. Bye-bye.